Today we're going to go down to Buenos Aires to Dr. J.P. Guyot, Juan Pablo Guyot, the chairman of the Argentina AO Spine Council. And he's going to talk about MIS and their experiences in their country under the era of economic restraints. We have some great visitors here from down south from Tacoma. Dr. Meyer and his group are here. We're going to introduce them later, and they have some cases to show also. JP, are you on live?
Yes, Jens. How are you? It is a pleasure to see you.
All right,
and
if not, we'll proceed with cases. So who of our fellows wants to go first? Do you have a case to go first? Which case do you have, Jerry?
An extension of a fusion that could potentially have done MIS.
Shall we, for starters, maybe go with our colleagues? Do you have your talk ready on a stick or?
No, I need to sign on and get out.
Okay, so let's start with Jerry, and I'll ask Ben to sort out the logistics for you to sign on.
All right, my name's Jerry Robinson. I'm one of the ortho spine fellows here. I wasn't involved in this case, but I'll be presenting it. I think it was done yesterday. So this is a 68-year-old female, status post multiple previous lumbar spine surgeries, and complained of left lower extremity and low back pain. The pain in the leg for about 6 months goes from the buttock to the foot. She ambulates with a cane for 2 to 3 steps, but is otherwise wheelchair bound. She does take chronic opioids and Lyrica. Was a smoker with COPD, but quit a decade ago. Here you can see her ODI score. And then you can see her surgical history. She had a 4-to-1 decompression fusion, an L3 to pelvis, and then a spinal cord stimulator placed about 6 months later. So you can see her neurologic exam here, relatively intact other than some proximal hip flexor and knee extension weakness. Here you can see her original fusion, which was the 4-to-1 with inner bodies, and then transitioned over to the L3 to pelvis. You can see instability with retrolisthesis at 2-3 and fish mouth gapping and instability on the flexion extension.
So Jerry, there are 3 different generations of cages there. Can you briefly name them from top to bottom or bottom to top?
Starting on the right-hand image, you have what looks like a traditional T-lift cage. Down below you have bone, and then I think these are like the screw threaded cages.
The ray cages.
Ray cages.
Ray cages. No, that's a ray cage for sure. I put in thousands of those.
And so MRI, we see adjacent level degeneration with stenosis and foraminal stenosis bilaterally left worse than right at L2-3, but otherwise great decompression. And then for completeness sake, we have a solid posterior lateral fusion on our CT scan. So planning at this stage, adjacent level.
So show us the neuromonitoring, the neural imaging. So there's a primary stenosis, and facet joints are congruous, right? So they're not. There's not a big fluid gap in there.
No, there's no facet
and go back
fusion.
to flexion extension films. How much of the patient's complaints are back pain versus leg pain?
It's from what I gathered in the notes, it's primarily left lower extremity pain.
So let me go to my colleagues from Tacoma. We have 3 of them here. Whoever wants to take the microphone first. This is an everyday occurrence, right? So fusion, no fusion. Let's assume that she has pretty significant radiculopathy and what I guess some neurogenic claudication. What are your thoughts in terms of motion preservation, a topping off procedure like an interspinous space? Oh, you have your own microphone there. Or just going to the next fusion?
So with that amount of leg pain, if there's any back pain at all, I would extend the fusion. If there was not a lot of leg pain, or if the patient was debilitated, sometimes I'll consider just doing a laminectomy, but discussing with the patient the significant likelihood that they'll develop further instability and require the fusion to be extended.
Dr. Martin, do you want to introduce your partners, left and right?
Yeah, Dr. John Blair and Dr. Yoss Kobe.
Yeah, in my hands, I would probably extend the fusion up to L2-3 and do a laminectomy at that level as well.
Let's see whether we have a 3 for 3 here. Yes?
I agree. It will also be a nice X-ray because you can put it on a new generation cage.
Which one would that be?
above.
Expandable from the side, the flank, obliquely?
Oh, probably one of those titanium coated cages or so. Yeah, not X-lift. No, thank you.
So it's an everyday
Ooh,
occurrence.
he said
JP, are you
not
live now?
X-lift.
Yes, Jens, how are you?
Hey, good. Very nice to hear you. I don't see you yet, but we'll see you later. So this is a common occurrence, stenosis, radiculopathy, 3 levels of fusions now with 3 different generations of cages, all successfully healed. Do you add to that? Do you add a 4th generation cage, or what do you do? Or do a decompression only with less invasive surgery, like what your title of your talk is?
The first question I would like to ask is the cause of the degeneration in the cephalic end. Maybe it has a lot of lordosis, this kind of patient. So I will probably extend the fusion, but I will try to protect the adjacent disc in the cephalad extremity.
And how would you do that?
I will probably do a lateral fusion, maybe an X-leaf, and then extend the fusion from the back part.
And that would be open then, right?
Yes, the lateral approach, it will be minimally invasive, but the posterior part, it will be open.
So what do you gain by adding an additional incision to the flank of the patient at the cost of already going through an already weak lumbar plexus and the psoas muscle, when you already have to open up the backside, which is an open procedure? What gain do you have?
I think that from a lateral approach, I will gain more height of the disc. I will have more correction, and I will have more place to have a good fusion.
Okay. All right. So I don't know where this goes, but I'll put my cap out there. I think about a decompression only. All right, Dr. Robinson, drum roll.
Do you have a full spine image? No.
I don't believe I couldn't find any like full length standing scoliosis films.
But you're right, JP. We should have a full length film.
Okay.
But the PI-LL mismatch is not, you can see it here, 55 PI-LL 60. So not a mismatch. But I'll show what was done, and then I'll throw out another argument for another option for discussion. But this patient got a T10 to L3 fusion with removal of the screw with rod-to-rod connectors, a lami, and an osteotomy. You can see their postoperative imaging here. And then since we are discussing...
Was there a spacer put in?
No, I do not believe so. No inner body.
So the connector was put right over the L3 segment?
Yeah, the screw was removed
So that's
and
going to be a
connected
weak
into
spot.
there.
And no cage?
No cage.
Okay. And the dorsal column stimulator, was that...
That was left in place. The patient stated that when that was put in, it dramatically helped all of her symptoms. So she wanted it left in.
So why no cage?
Just...
And how would you, because you're going to be an independent practitioner as of this summer in a very noteworthy major academic medical institution, how would you justify crossing the thoracolumbar junction?
I don't think that personally I would have done that in this patient, but I can't speak for the thinking of the justification from the surgeon that was involved. But I think mostly what was needed here was the foraminal decompression. And so that's why I threw out this option of a standalone X-lift for adjacent segment disease that's being done by a lot of minimally invasive people. I wanted to throw that out there to see what people think about that and see if that is believed to be a treatment option for this patient to
Fair enough.
completely avoid posterior surgery.
JP, let's start with you. So you wanted to go X-lift anyways, so transpsoas. So why not? You said you'd want to add a posterior reinforcement. Why not just do an X-lift? Why not trust that maybe with a little plate like what is shown here in this representative diagram?
Our experience was not good with standalone cages. We see a lot of subsidence and non-fusion. That's why I will do the X-lift and complete it with the posterior approach.
My partner, Dr. Hart, is here and he's nodding his head, but he has his mouth full, so I'm not going to put him on the spot. But what are your thoughts, Bob?
I agree with JP. I think, and of course, I haven't tried this, so I don't know in my own hands, but I've certainly seen the failures of fusion, and I think the mechanics are just, it's too much mechanically to control with one screw on each level.
Dr. Schoon is one of the three godfathers of XLIFs. I don't see you doing that. What happened?
So do you have the Scully x-rays?
He doesn't.
Okay, so she had, the problem with this person is she developed pretty significant kyphoscoliosis above the fusion. And then she had pretty severe central canal stenosis. And then at one level above that, at L12, she had pretty severe foraminal stenosis because of the curvature. And so I kind of went back and forth, and she really, wanted to keep her spine stimulator in. And then I think we're going to bring her back for a lateral approach and do 2-level interbody. But this surgery, this is one, again, where I had previously extended 1 level, and then she rapidly broke down. She's quite larger, as you can see. And she was really reluctant to come in after the last surgery I did. But I think between her, and if you look at her hips, she doesn't have great hips. So she basically developed almost a little bit of a camptocormia. And I don't think, if you look at the Scully x-rays, you'll see why I did the T10 of pelvis. I think she would have failed within a year if I wouldn't extended her. And so that was the reasoning behind going, and again, just because she's complicated, we wanted to try to do minimal in terms of blood loss. And so that's why we staged it. I think it took about 4 hours to do this.
Yeah, that left hip does look a little bit shady, doesn't it?
Yeah.
She had left proximal weakness.
It was mostly left lower extremity pain, but it was 4 out of 5 weakness.
Yeah. But the hip exam was normal?
Documented, I believe.
Okay. All right. What do we think about this? Super aggressive crossing the thoracolumbar junction? John Blair? Do you have to use a microphone, unfortunately?
Yeah, we only had one cross section through the lumbar spine, and my initial impression was to decompress because of the neurodeficit that she presented with on her examination. If it was just pain that you were treating, I would have tried to work with the spinal cord stimulator rep to basically see if they could modify that a little bit more and see if they could get her pain under better control. But with the neurodeficit, I think that doing a posterior approach and looking at the nerves is the way to go.
Yeah, she was non-op for about, I think, 6 to 8 months or something, and they did modify the stimulator about 3 months prior to intervention.
Sure.
So for me, this is a weak spot now with that extension. I welcome the thought that you didn't want to take out the whole instrumentation, but that anterior column is going to be a weak spot, so you'll probably have to be supporting that somehow. Bob, you agree? Yeah. All right. How's the patient doing?
The post-op day 1, and I think their leg pain's gone, so.
JP, what do you think? Was it super aggressive to cross the thoracolumbar junction? I know we don't have the scoliosis films.
I will try not to cross the thoracolumbar junction.
Is it true or not, and we can switch to Dr. Tataran, that the more we fuse on the lumbar spine, the shorter the survival time is? So the interval of collapse of 4-5 is much longer than the collapse of 3-4, is much longer than the collapse of 2-3 in these rostral propagations. Is that just my interpretation of literature, or do you agree with that?
No, I agree with you. I understand what you are thinking. I understand the surgeon that went up to the T9 or T10, I think it is. But even though I will try to go shorter. Okay.
Next case, Dr. Tataran with freshly cleaned, nice sneakers there.
Hey, I'm Zach Tataran, neurosurgery spine fellow here at Swedish. Of note, I was involved with that case yesterday. In pre-op, she was crying in pain, just begging for us to help her, like couldn't stand for 30 seconds. And post-op, her leg pain is gone. So,
cool.
Great success. It doesn't go to next slide.
Ben, we may need.
No, I just got to click. Okay. Oh my God. Okay, so this is actually a patient who we're doing today. This is a 75-year-old female, chronic worsening bilateral leg pain and back pain, thigh numbness, right lower extremity weakness, numerous recent falls due to the weakness, can't stand for over a minute. On EMG, she has right L5 radiculopathy. She has a history of multiple back surgeries, which I'll go through momentarily. Relatively intact exam, pain limited right lower extremity hip flexor. So this is her surgical history, which I'll kind of go through stepwise. This is what she looks like now. These are her Scully films now. But to go back from the beginning, in 2014, she had an ACDF in addition to right L1 through L4 laminotomy and medial facetectomies. This was her pre-op films showing severe stenosis, some mild coronal imbalance on her lumbar spine. So this is pre-op 2014. She was given, it was billed as a MIS, right L1 through L4 laminotomy and medial facetectomy. They did that with 2 McCullough retractors, it looks like, so I don't know how minimally invasive that was. This was followed the day after by a 3-level direct lateral interbody fusion, so that was kind of the minimally invasive component to this patient's surgical history. These are the intraoperative films of both procedures that were done one day after another. This was followed a year later by a L1 through L5 posterior lateral fusion with an L1-2 PLIF. This was due to lumbar stenosis, scoliosis, persistent back pain, persistent radicular pain. This patient was followed. She did well for a year or two and then started complaining of persistent back pain, persistent right radicular leg pain. So she had a right L4-5 and right L5-S1 laminotomy, medial facetectomy, foraminotomy. She seemed to do well for this for about 6 months, and then the pain returned in her back and right lower extremity.
Is that on the right side? If we go back one slide, is that the new kind of system of a down reverse load-bearing film? Is that a yoga kind of image?
No, this one, it was only lateral. I had to rotate
I was trying
it.
to make a joke. Yeah.
Oh. I had
for a yoga practitioner, I thought I recognized your. So JP, I have a question for you. So these cortical screws, they were sold to us as equally strong as standard pedicle screws. They're sold to us as requiring less muscle dissection. Are they equivalent? Are they less invasive?
I had very few experience with this kind of screws. But when I saw them that were mainly in lab practice or something like that, I didn't find a true advantage over the classical pedicle screws.
Got it. Okay, I couldn't agree more. There are many things to talk about. Pelvic fixation here. This is a postmenopausal woman, right?
Mm-hmm.
So postmenopausal woman, should one routinely go to the pelvis, or is that not necessary in a patient who has like a lumbosacral transition ossification here?
I agree with you, or at least I think what you are thinking, that a postmenopausal woman with this kind of surgery, we should go to pelvis as always we should go to the pelvis.
So that would be your agree. And then the final thing is a workup of a non-union. So that bottom level does look quite suspicious. On the right-hand side, it's the top level, since you have an cetus inversus, gravitatis. Do we routinely get a bone scan still, or do we just rely on a CT scan, JP?
It's a very good question, because the bone scan, actually, we can measure the bone density with a CT scan. I think we have to rely on the specialist, the image specialist, and try to trust on them. And I think that we should also trust on the endocrinologist to have a blood test and maybe urine test also.
So endocrinology and bone density workup. I'm going to ask our colleagues from Tacoma. I don't know who wants to take the microphone. It's really great to have you guys here. Thank you for coming. This is, again, a very typical thing. We see these cortical screws. We see kind of some alignment efforts. What are your thoughts? And I'm going to just take this one step further. I know this was not done here, but this patient ended up with a unilateral rod for some reasons that we'll clearly hear. What do you think about multifocal unilateral rod placement for patients who've had an anterior column reconstruction? Let's say X-lifts were done at 3 levels. And we've seen this a couple of times. We actually had a speaker here just a month ago who said, hey, you just need unilateral fixation. What are your thoughts on that? Multi-level unilateral rod fixation. Is that something cool, or is that just biomechanically ridiculous? Is that depriving the patient of their optimal chance for healing?
I don't do any direct lateral stuff. And I'm actually not familiar with the literature, but I would think that, I've done unilateral fixation in the past with really good inner body support, bone or a couple of cages up front, bilateral cages. If you preserve the facet joints, I think you can, I've had some success with unilateral fixation, but it's only over 1 level. I would be concerned that unilateral fixation over multiple levels like that is just seems to me intuitively biomechanically unsound.
We had a great systematic review actually by Bob Molinari, and again, there is literature support if you have a good anterior inner body for unilateral fixation with, I think, 1 level stable degenerative disease, maybe in a big maybe 2 levels. Bob, any thoughts?
Yeah, I think I would start by saying this case, if a patient looks like this with this history that's been operated on by one of our fellows, walks into my clinic, I'm going to send him to a good malpractice attorney. So this, to me, looks like, these are cases, I think, procedures. I don't follow the logic here completely, but this is, in my opinion, a little bit the surgeon treating themselves rather than the patient, making the procedure easy on them and economically beneficial. And other than that, I don't have any strong opinions.
Oh, wow. Okay. So Zach, take us forward.
So this is the intraoperative films of the right L4551 laminotomy, medial fascectomy, and foraminotomy. This was, again, done minimally invasive with a McCullough retractor. And then this was followed a year later, removal of the right L1 through L5 pedicle screw hardware. This was due to rod pain, hardware-related pain. So she presents now with severe right L5 radicular pain confirmed on EMG. Severe back pain, can't stand for more than a minute. These are her preoperative x-rays, preoperative MRI scan, preoperative CT. OR today. Any insights?
So JP, this is a new specialty in spine that I think has not been recognized adequately. That's the revision spine surgery problem. What are your thoughts when you see a patient like this, and how could this have been prevented? Was the signature of this patient from the beginning that this is going to be a decaying lumbar spine that needed a more global solution, or was this something that could have been averted probably at an earlier point?
I think that were a lot of mistakes made. Some of the mistakes were short fusion, not going to the pelvis. Some other of the mistakes, I think it is that they are assumed like there was a lumbosacral congenital fusion, and we can see a pneumodisc in L5 as one. I think that the sagittal restoration maybe is not the adequate, because we can see that the cephalad disc is also suffering. And maybe the more caudal disc, it was more for an A-leaf or something like that, because of the subsidence and non-fusion that was making. So I think that we can resume all the mistakes on that kind of things, I think. And I don't see that the minimally invasive decompression at L5 as one makes any sense.
Yeah, no, that was definitely another red flag. And that of painful hardware. That's, again, there are some cases where that may play a role when there's neurologic impairment, but other than that, that's more procedural rather than a causal factor. This is a case that I think has a new, or deserves a new 3-letter acronym. In orthopedics, we're taught ORIF. Don't raise your eyebrows, it's all going to be above board, Zach. ORIF, open reduction internal fixation. This is an OIF, an open internal fixation, maybe even a worsened reduction. So ONRIF, open no reduction internal fixation. But yeah, this is hard to see. But again, I'm sure all of us have made mistakes, but you've pointed out very eloquently a couple of principles. So what's your plan, Zach?
Plan is to go from or do a T9 to pelvic fusion. I believe we're doing inner bodies at the level above and 5-1. Yeah, 5-1.
Where do you guys think I should end this? Just one that everyone's in.
What's the bone density? And I would go to the pelvis.
Not great bone.
So what's the T-score?
I'm not sure.
What's the HU score?
Osteoporosis.
Let's ask JP, any tips on rostral? So sadly, Zach doesn't know the HU units of T12, or we can't use L1 here. But do you do anything for rostral stabilization in this kind of a patient as a transition zone? Do you use cables, bands, hooks?
No, we had experience with hooks, we had experience with bands, and we didn't find any beneficial with any of those. So we tried to end on pedicle screws, classical. I will like to ask you a question, yeah. About the T-score in this kind of patient, the spine is very difficult to evaluate. Do you evaluate it with the hips? Do you evaluate it with the wrist?
Non-spine. We routinely get a non-spine DEXA scan when spine patients come to us because the osteophytes have to be manually removed by the technician. And the other factor with DEXA scans, which makes them so susceptible for error, is the fact that each DEXA scanner, each hologram that's a company, has a different scaling. We didn't know that, but there's an about 10% error between machines. So ideally, you actually follow a patient longitudinally on the same machine. So that was an intrinsic technical problem that I was not aware of. But you're quite right. For spine patients, we get so-called non-spine DEXAs, and then we have to look at what joints are normal, where do they have joint replacements or previous surgery. So the opportunistic targets are obviously hips, elbows, wrists as the first thing. Distal humerus can be used. The hip scores are difficult to ascertain. They have to get 3 different cuts of those, so that's not straightforward. One of our fellows, Yev, is going to, I don't know whether he's back or he's still interviewing. Yev is back, wow. He's a professional interview traveler. He's doing an interesting study on opportunistic asynchronous CT scans for longitudinal determination. I think we're in the not too distant future going to have far more CT-based assessments rather than relying on the DEXA scan. I think that's a far more immediate tool. And maybe if Yev is showing a case, he can address that. Anything else to say from your end on this case?
Not at this juncture.
Not at this one. Good legal answer.
So what does everybody think? T10? How high should I go? What do you guys think?
What does the rest of her thoracic spine look like? What does the rest of her thoracic spine look like? It looks like it's auto-fused above that. Do you have flowing osteophytes throughout the thoracic spine that basically makes it fused above that as well?
It's kind of fused up in like T8, T9.
Right.
And then there's she's got stenosis and adjacent level disease. What's interesting is that I don't think it's actually fused. Her hardware is loosened. Even though there's all this bone graft posterolaterally, it's interesting because that's why they took out the previous hardware. But then if you carefully look at all these screws, they all have halos around it.
Right. And you're doing an interbody at 5-1 there.
I mean, the thing that's killing her is the L5 radiculopathy. And she's got a little bit of PJK at the level above. So I've been seeing her for like 5 years, and she's just finally, at the point where she's got a little bit of L5 weakness, and
her cervical spine's okay.
Yeah, she had a fusion.
Because
Yeah.
there's asymmetric clonus
Yeah.
on her examination.
Yeah.
It's true. It was
That's,
a bizarre.
that's old. So. So should I do cortical screws or do traditional?
Whatever you're comfortable with, but cortical screws are not less invasive, and the biomechanics are susceptible. But with navigation, clearly, it's become more tempting to try to fire artistic, non-standard screws. Dr. Plumer.
Hey, good morning. My name is Dr. Plummer. I'm an orthopedic trauma surgeon from Bochum, Germany, and also trained in Bochum, the University Hospital in Bochum. And I'm presenting an interesting case of a 43-year-old guy. He was quite a heavy patient with a BMI of 37. And presented with worsening back pain after a fall. He remembered and had a recent L4 to S1 MIS fusion at an outside hospital. And due to his pain, he was unable to work. Besides that, he had uncontrolled diabetes. Also, he was an active tobacco user and drinks on a daily basis. His neuro exam was quite normal, beside quite slight weakness of the EHL with 4 out of 5. And this is his CT on admission. It showed a failed single left-sided posterior instrumentation L4 to S1, a completely pull-out S1 screw with a disengaged rod. And also in the coronal view, you can see an S1 end plate fracture.
So JP, this is a phenomenon that we have in our country now that's become very hotly debated. And that is, number one, it's actually two parts. More patients seek to have surgery in so-called ambulatory surgery centers. Number two, these surgeries are increasingly done by non-surgeons, believe it or not, by interventionalists. Like this was an anesthesiologist who did the surgery. And the impressive thing is that this patient only had a moderate L5 radiculopathy. The cages were in the correct spot. The horror for us was the decision-making. This, what Jonathan did not tell us is this man had a huge belly. When he came to us into the ER on Christmas Eve a couple of years ago, was reeking of nicotine and did like his beer, but he was a business owner. He has his own shop. So do you have this problem in Argentina that we have interventional specialties doing spine surgery? And do you do these MIS surgeries in an outpatient center ostensibly to save money?
It is a very, very good question, Jens. In Argentina, we don't have that kind of problems of the interventional thing, but we yes have the problem is that sometimes marketing goes for above the decision making of making a correct surgery. So I think that we have to think clearly before making decisions. Because a failed surgery is even worse than a virgin spine.
Yeah, this patient had no previous surgeries. What went wrong here? Jos, you have a very critical look on your face. We just talked about unilateral rods. What went wrong here? How could this fail? Do you have an overview shot?
It's probably a mixture of, the selection was not very good. It sounds like the patient was not counseled on smoking cessation and alcohol issues. That's secondary, I guess. I'm not, I probably would have opted to do a GIL on a patient with significant radiculopathy. It generates a lot of bone, and I'm not quite sure how these. Did you say that these cages were put in anteriorly?
No, this was all done posteriorly.
All done posteriorly.
Through two parasagittal incisions. So he had kind of like a Wiltsy approach, but
Right.
one was very small and the other one was moderately large.
Yeah. So I assume there's not a lot of preparation typically going on. It's just essentially placing a cage like they used to do for threaded cages for A-lifts. There's not much prep. If you leave the majority of disc material there, you just put a spacer in, and that may work if you have a great posterolateral fusion, but that was not done probably either. So the fusion aspect was essentially neglected.
All right. You want to go ahead?
Only his MRI, and yeah, should I go on?
Yeah,
with the
just keep
treatment?
going.
Yeah. So what did we do? Removal of the screws, the rod, and the fractured fragment, also decompression, and removal of the L5 and S1 cage. And we put in new cages at the L5 S1 level, and also did a quad rod system from L4 to pelvis. Also an ORIF treatment of L5 and S1, as well as a separate wound closure with muscle flaps, because
Yeah, so the technical difficulty here was actually to get that posterior bone fragment off of the lower half of L5 that was actually sheared into the cauda equina, so that this man did not have a full cauda equina. It was a small miracle. The MRI doesn't show that. We took him to the OR pretty rapidly because of that. And we obviously gave him maximum mechanical stability. I want to give credit to Dr. Gottlieb, our plastic surgeon, who came in over Christmas to help wash out the very large seroma cavity that this patient had formed, and we were very worried about soft tissue healing in him. I think we took him back one extra time.
that's the next slide. So he came back 3 weeks after the revision surgery and had a staged debridement and irrigation because of the seroma, but there was no pus, and all cultures were negative, and he was set up to antibiotics, and he had a follow-up 6 months after the revision, and he was doing well. Slight weakness in the right on the right side was persistent, but he had a stable hardware fixation, and he also canceled all further appointments.
Yeah, so this is obviously a difficult situation, and we want to make it bulletproof. JP, tell us about quad rods. This is something that you have assumed doing more in Argentina, and in a patient like this, would you have gone from anterior to kind of give a larger cage support, or is the approach that we chose adequate?
We will probably do an anterior approach, as you are saying, but even though I find it a very good solution, I think this patient was excellent result. And I think it's one of the patients that we have to remark that sometimes MIS, TLIF, we don't think about the biologics of the soft tissues or even the fusion with only a cage anterior part. It's very difficult to have a fusion in this kind of surgeries.
We obviously used off-label bone morphogenic protein, but this is to show that, again, this is an ongoing debate that we'll have, and we don't have an answer here in our country, but we have more and more surgeries done in ambulatory surgery centers, and interestingly, we don't have any statistics. We have very good statistics nationally now on hospital-based discharges, and they're statewide and they're federal, so we have a handle on that, but the ambulatory surgery centers really are not accountable into the system. And the second thing is that interventionalists do more and more surgeries, and again, the selection criteria and how and why something is done really becomes secondary towards just firing some hardware into a patient. And for this patient, he was actually interested in suing the anesthesiologist, but the anesthesiologist disincorporated the company, and so there's nothing to sue. And he had signed a waiver. So this is basically an LLC, a limited liability corporation that no longer existed. So he had no legal recourse in the end. So any thoughts on, Micah, you've been politically involved, or yeah, John? Microphone, can you use the microphone?
So the ambulatory surgery center is no longer in existence as well.
And the corporation that stood for that is gone also and has dissolved, so.
All right. And what's the reason for the quad rods?
Pardon?
The quad
I
rods.
did not trust this patient. He had an extremely large gut, so I used the short, we call them working rods, for the L5S1 spondylolisthesis, which is basically a fracture dislocation at this point in time. And I used the spanning rods as a neutralization rod. The 4-5 segment, and I did not revise that cage, looked reasonably stable. And I connected the two rods with the side connector that a certain company makes to have more or less a unit there. So I want to make this as bulletproof as possible. I did not want to re-enter this lumbosacral spine if at all possible. Could be overkill.
Jens, I have a question, for you and for the other doc. So I suspect I know your but it's regarding non-surgeons doing spine surgery and calling it a procedure, whether it's done in a hospital outpatient setting or in an ambulatory surgery setting. I'd like your personal thoughts on it, but also what are Swedish's, what's the institutions stand on this? I know all of our societies are against it, but is Swedish doing anything differently? Do you
I
all
cannot speak
have
for Swedish. I'm going to take an immediate disclaimer status
Okay.
here. I do not represent the official stance of Providence of Swedish by any means. This is a very difficult subject. And again, I'm going to deflect the question a little bit. This is a subject for a much longer talk, and I'd love to have you and your group present for that because we're going to make this a highlight topic. The same subject in podiatry and orthopedic surgery, for instance, for lower extremity fracture care. It's the same subject in other subject areas like, especially areas like plastic surgery and dermatology. There are many dermatologists who represent themselves kind of as semi-plastic surgeons, avoiding that very title, and doing pretty substantial procedures and pretty sick patients sometimes. So we see this kind of infringement also in ophthalmology and optometry. So these para-surgical or para-procedural specialties are invading the traditional surgical spaces without the length of procedures. I can't give you a short answer for this. I mean, the minimum thing is that they play by the same rules and document everything. The limited data that's available in podiatry and orthopedic surgery is a vast overutilization of surgeries compared to orthopedic surgeons. That's actually in our peer-reviewed literature. With lower costs per procedure, but much higher complication rates. That's, again, just very carefully phrasing what is in our orthopedic literature. That said, our academy now is trying to kind of segue podiatry into a foot and ankle pathway. So there are efforts underway to kind of collect that into one common tent. So those are the dynamics in other specialties, and I think we should look at what other specialties do to guide ourselves. But offhand, nobody, at least our patients, are served by having metal put into a patient because something hurts them without trying to have a deeper understanding. And we ourselves are guilty at sometimes not adhering to those principles. So, Bob, you're nodding your head.
Yeah, well, it's it's an ongoing problem, and it exists in other specialties. And I guess we could also call out a couple where it's sort of succeeded, right? So cardiology has infringed on cases that previously were done surgically with success, and I think the same is true maybe in vascular, but to some extent, neurovascular and vascular surgeons have adopted minimally invasive techniques and in some ways kept sort of intact their patient population and have had less of that sort of intrusion. So maybe it's an argument for adopting MIS. I do think that and the topic of the program is really MIS surgery. I do think that's where things are headed, right? But we do have to maintain the principles of spine surgery as we adopt these techniques. And I think these cases that we've shown really highlight sort of technique over fundamental principles that we know to be important. And we're not going to succeed in that setting. And this notion of the outpatient surgeries, I think, is frightening.
Dr. Fravert, one more case from us. Fire away. I'm curious what you selected.
And then just want to quickly mention, we were talking about the bone density measurements from one of those previous cases. I did a quick measurement. The bone quality actually looks pretty decent for that patient that we discussed.
What is the critical HU thing, and which vertebra do you usually use?
So we're still doing the math, but for my study, we're looking at both the UIV and the UIV +1. There's a couple benefits to looking at both. Part of it is data availability, but part of it is just an actual predictive value. But there's more to come on that.
What's the critical number?
We're looking at around 100, 110 maybe the limit, but the statistics aren't done yet.
The cutoff from our academy in the Paul Anderson reference paper was 110 for osteoporosis.
So I think 110. we may be matching that, okay. But it's still not fully formalized.
All right, fire away. Can't wait.
So our patient in question is a 67-year-old male who presents after a mechanical fall with no loss of consciousness. He developed gradual onset of back pain about 3 or 4 hours after falling. and then that back pain was subsequently refractory to routine analgesia. The patient presented to the ED for further evaluation. Really, only major history is that he was a former smoker, pretty extensive, I think 20-pack years, something like that. No other major medical or surgical history. On exam, patient is full strength, no sensory deficits, does not really tolerate being upright, and has notable midline tenderness to palpation of his lower thoracic spine. These are his images here. This is the CT. On the left there, you can see, just a hint of a fracture right above T12, which is somewhat better visualized on the other imaging. This is the MRI demonstrating primarily soft tissue disruption. This is I guess you could classify this as a ligamentous chance fracture between T11 and T12. This is a situation we see pretty frequently. Patient with a picture that looks like ankylosing spondylitis and a through fracture. There's always a lot of debate in terms of what to do in these cases. Sometimes these patients can be managed non-operatively. MIS options certainly exist, and then open fusion is also a possibility. We spoke pretty extensively about the possibilities for this patient, and we even, pretty seriously considered non-operative management. Unfortunately, the patient could not really tolerate weight bearing without a brace, so we offered the next stage of invasiveness, which was a percutaneous fusion. Navigated from T9 to L2. The intervention went uneventfully. The patient was discharged post-op day 4 to sniff with a TLSO, and he's actually doing well several months post-op. That's a typo, not several weeks. These are his post-operative images. Pretty easy to contour the rod to that region of the spine. Kind of a nice clean MIS outcome compared to some of those other cases.
All right, so JP, ankylosing spondylitis and dish patients have inundated our emergency rooms. I mean, this is the new leading cause of trauma for us. Has this been the same observation that you've had in Buenos Aires?
Yes, I think dish patients are not as usual in Argentina as in the United States, but it is as the AO classification, the actual classification, it is a modifier, the thing that has spondylitis, ankylosing spondylitis or dish, and we have to treat it not as a normal patient, but as a patient that has something different. I agree with your treatment. I think the percutaneous screws is a very good indication. But one of the things that has this kind of patient is that they usually have a sagittal imbalance. So with the percutaneous screws, you are not correcting the sagittal imbalance, you are correcting the fracture. But maybe in the future, we have to do something else in this kind of patients.
So would you have done the same thing, or would you have done a combined surgery where you kind of do a opening wedge osteotomy with a small open procedure?
No, I think I will do the same thing as you did. Maybe not navigated screws, because we don't have the possibility of navigated screws in Argentina, but yes, percutaneous screws, because you have to try the fracture, not the imbalance, the sagittal imbalance. If the patient after that has any sagittal imbalance, maybe you have to do an osteotomy, and maybe the osteotomy has to be below the place where you are doing the fusion.
So Dr. Hart sitting next to me, he's published a paper or two about sagittal imbalance. We also know from our literature, we actually published on that in Journal of Orthopedic Trauma, I think 4 or 5 years ago, that the complication rate when you try to correct a deformity in an ankylosing spondylitis fracture opportunistically, it goes much higher. So Bob, tell us about this conflict of sagittal rebalancing versus just getting the fracture to heal.
Yeah, I think it's a great point and a great question. I guess in my own experience, if the fracture has occurred at a level that is logical for an osteotomy, I have in some cases gone ahead and done the osteotomy in addition to stabilizing the fracture. In this case, that's not what's going on. We've got a fracture in the thoracic spine. It's not the right level for restoring lordosis, really, and so we focused on just stabilizing the fracture. But I agree completely with JP's comments. This patient is out of sagittal alignment. You can see that they're retroverting their pelvis. So this is really, we could call this compensated sagittal malalignment. But it hasn't been presumably, and I don't recall really the last time I saw this patient, but I think if he comes back with concerns that suggest that's a clinical problem for him, then we'll address it then. And this was really just managing the fracture. And just to underline it for the fellows and anyone else, the benefit here of using percutaneous screws is you don't need to obtain a fusion, right? He's already fused. So at the level of the injury T11-12, we did pack some bone graft and bird out the facets just through the percutaneous stab holes. But other than that, we really didn't, you don't have to, and we didn't try to do a formal fusion.
I think these are great points. For the fellows, I just want to point out that classically 1 in 5 patients have a non-contiguous fracture from the sentinel main fracture that everybody jumps on. So we have to be aware of that, and we have to pan scan the spine. And a third of patients have an epidural hematoma. If you go forward or backwards, I think, to the MRI scan, it doesn't show that. I'm a little bit worried that there's a cord signal change, but maybe that's this conus flare.
Yeah,
but there's no visible epidural hematoma. Would that have changed your approach? Sorry, you're being talked to right now. Let's ask Dr. Martin and his team. Would you have done this percutaneously? And what are your thoughts on open reduction and decompression in a case like this?
I would only do something open as far as decompression goes if you had some neurologic compromise. Without neurologic compromise, percutaneous screws are the perfect thing for this. They're fairly easy to reduce, and you're really just, again, stabilizing a fracture so you don't have to rough up those joints. And the pain relief is dramatic. I mean, they go from being unable to move around in bed, they can't get up without a brace, and most of the times they're up the following morning and wanting to know when they can go home.
Would you have given this patient a brace trial just to attempt it?
So it's funny, when you started to present this, I had a guy that walked into my office about 2 weeks ago who had a similar fracture, but it was a month out. But he didn't have any disruption posteriorly. It was just through the anterior part. And because he'd been a month out and he was sagittally imbalanced and forward flexed and didn't like to lay down, so he never gapped that thing open. And we ended up treating him just in a brace. And he's doing fine in the brace and he should heal. But I think that there's a bony disruption either through an area that hadn't fused, looked like it was a T10-11 on the CAT scan. So I would have probably just operated on him right from the get-go and not given him the option, just because putting those percutaneous screws in are quick, they're easy, and they're a minimal physiologic insult to the patient.
Great. No, I mean, I largely agree. I actually, in neurologically intact patients, give them the bracing try, but I look at their abdominal bulge, and I'm very cognizant that they have poor secondary respiratory function. They have to try to breathe through their abdomen. They have frozen ribs, so it's a real challenge, but they have to be super compliant, and those are usually strikes that rapidly minimize the non-surgical treatment. Any insights for you, Yev?
No, this is a case I've seen multiple times. I think we did the right thing, and the proof is in the pudding. The patient could not tolerate being upright at all pre-op, and then immediately post-op was essentially dischargeable. So,
beyond all measurements, the ultimate sign of stability is a mobilization of the patient. If they can't stand it,
exactly,
that's an unstable spine.
Exactly, the functional result trumps everything else.
So it's a great honor to introduce our honorary guest speaker today, our STED speaker, JP Guyot. He is the Messi of spine in Argentina. I've had the great pleasure of visiting our colleagues there. Their quality of care is amazing, and their teaching is extremely vigorous. He's the chairman of the Council of AO Spine in Argentina. And full disclosure, we have to give our conflicts of interest. I'm a fan of his, and he's a former fellow at Harborview, and I still remember your amazing contributions there. So your insights and your skills are dramatic. And the reason why we're so interested in hearing from you, first of all, it's great to see you, although it's digitally and virtually. Your country is obviously, it's a great country with a great tradition, has been beset by significant economic problems. And we thought it would be very interesting to see how MIS has fared and what role MIS has in a country that has had significant fiscal problems in terms of covering healthcare. So your thoughts will be very much appreciated as we're entering economically difficult times here as well now. So please educate us about MIS and your experiences, how that has helped deliver quality spine care in Buenos Aires and Argentina in general.
Thank you very much for this introduction, Jens. I think I do not deserve this kind of introduction. And I really appreciate the time I spent there in Seattle. So it was a pleasure for me to give this kind of talk. The idea is to make a critical review of MIS techniques, to see some kind of costs and to see some kind of the alternatives that we have in this kind of surgeries. I am Juan Pablo Guyot. I am from Buenos Aires, Argentina, and this is the hospital where I make my main jobs. When we talk about MIS in spine, in the recent years has gained popularity, mainly because it has better retractors, instrumentation and cages technology has improved, illumination and amplification system has also been better in the last years. Maybe the objectives are decreasing muscle damage and trauma, decreasing intraoperative blood loss, decreasing surgical site infection, and decreasing length of hospital stay, as we were talking in some of the previous cases that we were talking about. But is it always this way? When we start to evaluate our first cases, we have this kind of things where we have a low-grade spondy at L4-5 with a stenotic canal. And most of us, some years ago, will have no doubt of making a fusion with a T-leaf at this space with a posterolateral bone also to make a 360 circumferential fusion. But when we start to make some literature review, we see some meta-analysis that there is no evidence that fusion is better than non-instrumented decompression in lumbar spinal stenosis. Single decompression results in lower surgical time, reduced surgical blood loss and length of stay, and apart from that all, improves walking ability. So with similar cases, this one has no spondy, degenerative spondy at L4-5, but yes, it has the left facet joint that has liquid and maybe is some kind of indirect instability. We started to make it with tubular retractor and make some single decompression without fusion. These kind of techniques were improved in the last years because in the beginning we made a midline incision and maybe full laminectomy. And after some years of practice, we can do techniques like over the top with tubular retractors and with the microscope assistance. The advantages of the over the top decompression, it's like with an uniportal approach, we can do a bilateral decompression, making a central decompression, contralateral foraminal access, and no lesions of structures needed for mechanical stability. So we start to continue revising our cases, and we can see that one of these cases that has some kind of instability or degenerative spondy at L4-5, we can also use an over-the-top technique with excellent results. But our main doubts are which are the revision predictors in lumbar spinal stenosis there is some articles that talk about facet orientation, facets that are more sagittally oriented, maybe over 50 degrees, or this heights over 6.5 millimeter, or the dynamic stability, or maybe those sagittal disc wedging at some kind of level are a bad indication for these single decompression techniques. Even though we are crossing our limits, maybe sometimes it comes the authorization of implants, or maybe some administrative complications. We are crossing the line, and maybe some patients where we can have this height and sagittally orientated facets, we can also do the minimally invasive decompression with not a bad results. Even some cases where we have a long construct with clear signs of instability in the lower part, with the idea of having rapid or quickly rehabilitation, we are doing just decompression and we are having good results. But I think it's not always like that. We are actually talking about endoscopy. We don't have many endoscopy systems in Argentina. So we are trying to look for literature. This is an article published in 3 years ago, where it's made a retrospective analysis on prospective, analyzed 45 patients in which they have 19 treated with MIS and 26 treated with endoscopy with 1 year follow-up. And they see that the OS3 disability index scores are in both groups. And we have to talk about last year paper where they make a meta-analysis over 27 studies. They found some advantages in time of surgery, OS3 disability index, and overall complications in surgeries where disc extrusions are the main cause. So they are suggesting that endoscopy may be the next gold standard. But will it be the same for all time of decompressions? That is one of our big questions. This is a patient where we see with clear signs of instability, maybe mainly at L4-5, but also at L3-4, that consulted with left sciatica, invalidating sciatica. And we started to think if the better idea was to make 360 circumferential fusion from L3 to L5, or try a minimally invasive surgery, maybe some kind of troubles with the administrative things. We induced our surgery over just a minimally invasive surgery with a very bad result, with a patient who had more instability and more pain in the postoperative period. So finally, we made an open 360 fusion. So we can do comparative outcomes of minimal invasive surgery when we think about posterior lumbar fusion. We were talking about length of stay, that is one of the main concerns. Equivalent blood loss and equivalent reported patient outcomes show a slight benefit in favor of MIS procedures, but we think that not all the pathologies are the same. And this article states if our results biased by industry or not. So this is one case that we received similar to what you showed in the previous cases that we were talking about, where it had just a black L5 disc, which was treated with an MIS T-leaf, which was a clear sign of pseudarthrosis and clear signs of movement of the T-leaf, where we made an A-leaf and we made an open revision of the posterior part, making a circumferential fusion. When we talk about MIS T-leaf, we find lack of evidence. Is this a procedure where it reduces soft tissue damage? We don't think about biologic. Is it enough a T-leaf to generate anterior fusion? And what about elderly patients and the subsidence it generates? So what we are actually making some experience, and we are watching very good results, it is with the O-leaf. We find it better that MIS T-leaf in length of stay, operation time, and serum creatinine levels. O-leaf showed better restoration of disc height and lumbar lordosis angle that we are very concerned about nowadays. Maybe complication rate was higher in this article, but I think that curve of experience is making some kind of things. So these are some of the cases that we had surgery. This was a patient that had discitis sequela that was making kyphosis of L4-5 and was not resolving his infection. So we decided to make an O-leaf and percutaneous screws. Or this other patient that has a similar thing as the other one, but with epidural abscess, that we did it on a posterior open approach, decompression, and then we made an O-leaf, just an O-leaf approach, just to continue with the curette and removing all the kind of infection that was remaining. So as conclusion, I think the MIS techniques have grown in the last year. No doubts in the benefits of non-instrumented decompression, but I think we still have to put in order the indications and which are the patients that we are crossing the limit. Maybe in our country, administrative things make that we are crossing some limits, but I think this have to be rethink. I think one other conclusion that we are making is MIS T-leaf the ideal fusion technique, or is it O-leaf, or are we moving our tendency according to what industry is biased? And what is the future? Is endoscopy, is that a very high cost with no real benefit? I think these are the future questions that we are having nowadays. Thank you very much for the invitation.
Great job, JP. Accept our applause, and I'm happy to tell you that our actual meeting room is getting fuller and fuller again, so you had the benefit of one of the larger audiences there releasing our restrictions. So I have a couple of questions for you. So first of all, your images look very nice. I know that private patients in Argentina have to prepay for their implants. Is that right?
Yes, that's okay.
Implants. So do they pay a higher price for MIS implants? Usually the companies here charge a higher price for cannulated equipment and things like that. So do you tell the patients, I'm going to give you an MIS surgery, but you have to pay, like, let's say 30% more. Is that the reality in Buenos Aires?
Yes, that's right. Here they have like an insurance. With that kind of insurance, they have the possibility of going with very bad quality screws that we are not accepting, that kind of bad quality screws. If they have to pay some kind of money, they access to better screws with open procedures. And if they want MIS, they have to pay even more, maybe 30% more, as you are saying.
So since we're on the subject of economics, endoscopy here. I mean, it's fascinating when we work in our Seattle Science Foundation lab with it. I think it's very compelling for extraforaminal decompressions. The problem here is for a hospital-based approach, and I'm a hospital-based surgeon, it's not affordable for the hospital. There's no insurance surcharge that covers the disposable cost for MIS, and the hospitals are forced to pay for these machines that you need, the drivers and everything like that. So this is a big deal here, and where endoscopy can flourish in theory is in outpatient surgery centers. So how is that for you? Do you have patients pay for their endoscopy equipment, the disposables, and how do you afford the numerous towers, the optics, and the mechanical components of this?
I think it's an excellent question, and one of the biggest problems that we have is that we don't have endoscopy. A good development of endoscopy, maybe because of hospitals can't afford the towers and all the disposable things. So the few people that make endoscopy here are people that maybe they bought the tower from on a journey that went to Germany, for example, and went to the States and bought some other garrison specific, and they are like mounting their endoscopy the way they can. But I think it's not the way endoscopy has to be developed.
So we have the great fortune of having Dr. Martin here and colleagues, spine surgeons from large sister city of Seattle, Tacoma. Dr. Martin, you're the chair of one of the largest, actually the largest surgeons group here in the Puget Sound area. What are your thoughts on endoscopy? How do you handle that? I know your group has surgery centers. Is this a technology that is making an inroad, and how do you kind of economize the additional surcharge of that technology?
So thanks, Jens. Not the chair, but involved with ProAlliance surgeons. So it does come down to economics, and we do a significant number of outpatient surgeries for orthopedics, but also for ENT, general surgery, and women's health. But it comes down to economics, and the way that it works, we're very conscious of what everything costs, because that's what drives the efficiency of we're paid a flat fee by different insurers for whatever CPT code is that we're using, and it's up to us to determine, do we want to spend a lot of money on implants and disposables, or is there a way that we can do it without spending that money? So I think the economics of it in that regard forces our surgery centers, our surgeons, our administrators, and our patients to take a look. We encourage our patients to look too, because driving down the overall cost of the procedure lessens the out-of-pocket costs for the patients. Happily, I think things are better for us than it sounds like in Argentina, where folks have to pay the implant cost ahead of time. We don't have that here yet.
Yeah, this actually, I found that disturbing and fascinating and interesting all at the same time. When I saw it in Argentina, I mean, it's very honest in a way. I mean, the patient literally pays for what they want, and they have an option. They can go for a government-made implant, which is probably not the same material standards, is not terrible looking, looks suspiciously like implants from main manufacturers, but I'm not a copyright patent attorney. But, or they can get a quality implant. And again, the surgeon actually serves as a representative. So while we find that ethically reprehensible, the patient gets exactly what they want, and the surgeon serves as the intermediary. And the price surcharge for the surgeon is actually upfront. The patient knows exactly what the surgeon's cut will be. So we're in a weirdly socialized atmosphere in the US, actually. So to put you on the spot, is endoscopy then, spinal endoscopy for decompression surgery, a reality in your surgery centers or not?
I haven't been keeping up with the surgery endoscopy things. Anything, for me, I think in our care center, anything that drives up the cost is something that has to be scrutinized very clearly. It has to have some significant improvement in patient outcome. Clearly, if there's a big improvement in patient outcomes, it'd be something to seriously consider. But it has to be balanced with cost as well. But as far as I know, we're not looking at anything endoscopically. John, are you aware of anything?
So let me ask for another big push on industry, and that is navigation and robotics. Are those factors in your surgery centers at this point in time? Have they made an inroad there because they have an incremental value added?
We, as far as the spine stuff goes at ProLiance, we're probably a little bit behind most other outpatient centers. So to my knowledge, there are not any navigation systems for spine. We're doing primarily laminectomies, anterior cervical fusions, very few lumbar fusions currently.
So, JP, tell us about the reality in your surgery centers. How does that work, or in your facilities? Do you have navigation devices? Do you use robotics? Is that a helpful adjunct for your dedication towards less invasive surgery?
Most of our minimally invasive surgeries are with X-rays. We don't have a true possibility of making navigation because it's very difficult to obtain an intraoperative CT scan.
So we, by the way, have a, do you want to go up there and pull up your craniocervical case? Yeah. Ben, can you give Dr. Martin access to the computer? So we have a case from Tacoma, craniocervical case. So we thought we'd give you that as a little parting gift, JP. Dr. Sohail, Tarek Sohail, is from Lahore. Tarek, give us your thoughts on less invasive surgery and industry pushes versus patient demands and MIS surgery and clinical reality.
I think MIS surgery is very much being introduced in the market here. We are doing it to a certain extent. And we're doing, in my hospital, we are doing transfemoral endoscopic discectomy, but we have a limited sort of indications. But coming to the implants, so we don't manufacture here, except one or two manufacturers which make exactly the same, which appears to be genuine one, but they are very flimsy in their, sometimes they break during insertion. But most of the market in Pakistan, we get it from the China, which are making, I don't know, they put up the mark, which is as if it's, some German or some American companies there, but I'm not sure but they work very well and they're reasonably economical as well as compared to the big companies in the world. The metallurgical point of view, I think they are reasonably compatible with the insertional technique and subsequent their longevity and their resistance towards fatigue and fracture. So I think we are quite happy with the Chinese equipment and implants, and they make good instruments, but they are not as comparable and as good in problem solving as one Medtronic, which are the leader in the field. They are not as good as that, but nevertheless, they serve the purpose most of the time. Similarly, they also market cages, various cages. Now they are coming up with the expandable cages, which are sometimes they're cumbersome to put up, but they're okay most of the time. Coming back to one of the cases in which they had, yes?
All right, who drives this development? Is this the industry representatives, whichever country they come from? Is it the patients, or is it the surgeons who want to develop different skill sets? Who drives this?
No, I think it's a market surgeon demands and the patient demands, or the surgeon demands good quality and the patient demands economy. And the patient, since they are not very well educated and they are not very well aware which kind of metallurgy and what kind of design and what kind of, the threads or whatever, they want the less price. So there has to be a marriage between the quality and the price, and that comes from China. And that's a reasonable, I would say. The surgeon, even if they give input or we give them input that we want this kind of design or this kind of implant, they they are very reluctant to design to your requirement, but they will certainly get the near enough variation or the implant design as they would see in China, or they would have been marketing in Europe or other countries. But by and large, the Chinese, what we are getting is reasonable in quality and price as well. So I think that's what we are going with, and that's what we are, I think, we are managing reasonably well with that.
JP, in Argentina, and 2 weeks ago, by the way, we had Dr. Viale from Brazil, so it's cool to have Argentina and Brazil represented here. They talked about the local market and local industries, which may or may not imitate some so-called Western implants. Has there been a push towards MIS implants from the local manufacturers as well, or do they stick with the standard nuts and bolts, so to speak?
According to the local industry, they are making like tubular retractors. I think that there are many copies of the tubular retractors, but according to MIS percutaneous screws, they are very, very few in the local industry, and the quality is so bad that I prefer not to use them.
So when you want high quality retractors, do you have to go more or less have the hospital buy them, or do you buy them yourself and then market those to your patients? How does that work?
We usually tell the patient, and sometimes his insurance covers that. And when the insurance doesn't cover it, we ask the patient if he can afford the difference. Because we truly think that the tubular retractor is much better than a traditional discectomy or something like that. I actually don't see a true benefit in endoscopy versus tubular retractor, but tubular retractor according to classic discectomy or classic laminectomy, I really see a benefit there.
Great. Any comments, Bob?
This is a great talk, and I do think it's important to innovate and move techniques forward for our patients, and I do think minimal access offers that sort of approach. I think I already talked about not losing sight of the basic principles of spine surgery, which is how to get fusion biologically, how to get stabilization biomechanically, how to get decompression. And as long as we hold on to those and succeed with the new techniques, I think it adds value. I do think there is a second question we need to always evaluate too, which is that one, does it add value? And I appreciate your comment, JP, that the tubular retractor feels or seems to give less impact of the dissection. But we're competing against a very successful and very limited procedure in a one-level laminectomy or one-level laminotomy. So it does feel at times like we're kind of operating around the margins of something that we can already do very quickly, efficiently, safely, and with benefit for the patients. So there's a high bar in my thinking in that regard.
So I'm going to ask Dr. Skuyan. So you mentioned XLIFs versus OLIFs. You have to use, I'll give you my microphone. Or can you pass that microphone over? So he's one of the three people who was a very early adopter of XLIFs and helped develop retractors and everything. And I've not seen you do that many anymore. What's your perspective on XLIFs now? Is that a kind of a technique that's come and gone, or is it now being rejuvenated with a prone transpsoas, a PTP type of an approach? What happened with XLIFs in the big picture?
No, I mean, I think, I do think that there's still a huge role for it. I think patient selection is really important. And I think, everyone talks about doing MIS, but I really think, MIS it's kind of a catchphrase that people use, but I mean, I think lateral surgery is probably as minimally invasive as you can do. I mean, we've done these, multi-level lateral procedures through a small incision, corpectomies. I mean, I think for me, it's still the workhorse in certain parts of the spine. And it's a very elegant way to access the spine. You know, you're going through a corridor, you're not going through, you know, muscles really, and you're kind of creating working actually in the disc space and are able to get a lot of correction through 1 or 2 levels. So I still think it's a super valuable approach, whether you go anterior to the psoas or transpsoas, that's up to the surgeon.
JP, you kind of inferred that you were more inclined to do OLIFs and XLIFs. Is that something I just overheard, or is that based on some clinical experiences?
You are correct. We are having a higher tendency of doing XLIF and OLIF.
And why is that?
We think that it gives a better correction, restores lumbar lordosis, and has a better surface of having biologic to have lumbar fusion. We are not doing standalone, as we were talking previously, but we can do all that kind of things with maybe percutaneous screws or open screws if it's necessary.
Well, it's very cool to hear you. So we were going to show you a craniocervical case that was in Tacoma just last weekend, and that Dr. Martin did a beautiful job with, but we can't get online. So I think we'll have to conclude our session today, is right?
Yeah.
But thank you for being willing to show it. So JP, it's great to see you. Thank you for sharing your experiences from Buenos Aires. It's fantastic to see you. I wanted to make a pitch for the next STED Talk, which is June 1st. We have a controversial topic. It's called Women in Spine Surgery. And our former director of AL Spine North America, Liz Walker, just wrote a PhD thesis on this. And she did a very systematic analysis of women in spine surgery. We have a female resident surgeon from UW, and we have a practicing orthopedic surgeon. She's not a spine surgeon, from the state here. And they're going to basically share their experiences as females in orthopedic surgery in general. And that goes for neurosurgery also, because the numbers are equally bad, and spine surgery specifically. So please tune in June 1st or join us here live, since we're open again. And I want to again acknowledge and thank our friend JP Guyot, and hopefully we can meet in person in the not too distant future. Thanks, JP. Thanks, Tariq, for dialing in Lahore.
Thank you, Jens. Thank you, JP. Okay, bye.
Thanks to you all for the invitation. It was a pleasure for me to participate.
Thank you, JP. Thank you, Jens.
Bye-bye. Thank you very much.
Super interesting. One thing that amazed